that had elevated bile acids with no clinical signs. We did a CT scan at the time and found no evidence of a portosystemic shunt. So we sent him over to internal medicine, and they decided after a period of workup that we needed to do liver biopsy. And so that's what we're here for today. If you haven't done so, please subscribe to our channel. Make sure you turn on notifications. Now, this is the first time that I'm streaming on VetDojo in about 7 months. For those of you that don't know, I have a new channel called VetAlign, VetAlign, which all of my streaming is going forward. And so I'm streaming on VetDojo just as a segue to get you guys to switch over to VetAlign. Again, it's VetAlign. So I'm doing a midline abdominal exploratory in this little dog. And key things when we do an abdominal exploratory are, number one, we want to make sure that we have a wide enough or a long enough incision so that we can actually see everything that we're looking for. So midline abdominal, through the linea, nice long incision. Apologize if my head gets in the way. Right, I'm a little bit off midline here, but not too far. That is not catastrophic. It's a nice long abdominal incision. Is the first thing. Next thing is that we always remove the entire falciform, because that's going to make it a lot easier to see. And when we make our incision, we want to go all the way up to the xiphoid. And in male dogs, we want to go all the way down to the prepuce. Those of you that are joining late, this is the first time I've streamed on VetDojo. We are getting light in about 7 months. My new YouTube channel is called VetAlign, VetAlign, which is where most of my streaming is going to be going in the future. But I'm streaming on my old channel just as a segue so that you guys know about my new YouTube channel. So from the xiphoid all the way down to the prepuce, remove the falciform. And when you remove that falciform, you want to cauterize those 2 blood vessels that are on either side of the falciform. And otherwise you will have dripping of blood into the incision. Next thing we want is to use Balfour retractors. So Balfour retractors for medium and large dogs. For cats and small dogs, you can just use Gelpi retractors. Now we use this spoon, and the purpose of the spoon is basically just to centralize the Balfours. Alright, so now we can see that we've got a nice wide incision. We can see into the abdomen really clearly. Now once I got my Balfours in, it stretches things out a little bit so I can extend my incision a little bit more. Now the first thing that I do when I'm doing a neck flap is I always look at the diaphragm, and I've had a couple of cases where unexpectedly I found either a portosystemic shunt on the diaphragm or I have found a diaphragmatic hernia. So we've got nothing there. So that all looks pretty normal. Next thing we're going to do is express the gallbladder, and by doing that, or the way that I do that is I just grab onto the gallbladder and gently squeeze it. Just make sure that it empties as I'm squeezing. Then we're going to look at the whole liver. That liver looks extremely healthy. Nothing wrong with that. So I'm going to look at all the lobes of the liver. can help to remove the spleen and pull that out of the way. So I'm looking at all my liver lobes, and that all looks really nice and healthy. So we've got the stomach here. So the next thing that I do, once I've looked at the diaphragm, I've looked at the liver, expressed the gallbladder, I'm going to palpate the stomach from the cardia to the body, to the antrum, into the pylorus. And then as I'm looking at the duodenum, we can see our Peyer's patches sitting there. We did not put a purse string in the prepuce. We've just flushed it out. So as I'm using my duodenum, as I'm looking at my duodenum, I'm going to use it as a retractor and pull it over to the side. And then by doing that, it's making a duodenal basket, and I can see lots of other little structures. So what can I see here? I've got pancreas, right limb of the pancreas there. I've got my portal vein sitting right there. Got my hepatic artery right there. And just a bit of party trivia, that hole underneath that hepatic artery is called the epiploic foramen. And if I stick my finger in there and squeeze the hepatic artery and the portal vein, that's called a Pringle maneuver. And by doing that, I'm interrupting all the blood supply to the liver. And that means that if I've got a bleeding liver mass or a bleeding liver laceration, can't control the bleeding, that's going to stop all the blood supply to the liver and allow me to address the bleeding. I've never actually used that clinically, but it is good party trivia. All right, so now I'm going to have can I get some saline, please? Have my assistants here, we're tucking all the guts behind the duodenum. I'm going to have my assistant just gently retract on that duodenum. And I'm going to try to find the right adrenal gland, but I won't be able to see it because you can't see a normal adrenal gland, right-sided adrenal gland in a dog. See the vena cava right there, and that's going into the caudate lobe of the liver. That's probably the hardest liver lobe to remove a mass. I've got the right kidney sitting here. If this were a female dog, we would see the right ovary and right ureter. Not sure if you guys can see that, or right ovary and right uterus, uterine horn. I don't know if you guys can see that, but I've got the ureter sitting right there. Okay? Now, as I come around the corner, I've got a structure here that's keeping me from exteriorizing the caudal duodenal flexure, and that's called the duodenal colic ligament right there. And so that's what's keeping me from exteriorizing it. If I needed to break that down because I had a foreign body or a tumor here, I could do that. There's no problem. In this case, I won't have to. Now, as I round the bend around that caudal duodenal flexure, I get into the jejunum here. And as I bring out the jejunum, I can see my mesenteric lymph nodes sitting right there. You cannot remove the mesenteric lymph nodes because you can see that all the blood supply to the jejunum goes into those lymph nodes, and so you cannot remove them. You can biopsy them, though, if you need to. So now I'm running my jejunum, looking for any masses or foreign bodies or anything like that. This dog has no gastrointestinal signs at all, so I'm not concerned that I'm going to find anything. Now, as I come around to the end of the jejunum, I can see that anti-mesenteric vessel right there. That tells me that we're in the ileum. So by definition, that is the ileum. Then I have my cecum here, and I'm going to use my colon as another retractor to look at the stuff on the left-hand side. So as I bring that up, I can see the left kidney, the left adrenal gland, and I don't know if you guys can see that, but that's the phrenico-abdominal vein sitting on top of the left adrenal gland right there. And so that phrenico-abdominal vein tells me where the adrenal gland is. And then we're going to run that colon all the way down, and I can barely see the tip of the bladder. Stick my finger in here and try to palpate for enlarged prostate or anything like that. So that's pretty much our XLAP there. I'm going to have another closer look at the vena cava to make sure that there are no abnormal vessels coming into the vena cava that would be consistent with a portosystemic shunt. So I've got my left renal vein there, my right renal vein is there, and I don't see any abnormal vessels coming in. Now, this is not something that I normally do in abdominal exploratories, but because I'm so concerned about the potential, oh, here's the left limb of the pancreas right there. I'm concerned about potential for a portosystemic shunt, that I am going to make a little rent in my omentum, and that's going to allow me to have a look down here, and I'll see if I see any abnormal blood vessels. So these are all, that's mesenteric veins there, and I don't see any abnormal vessels. And again, I've done a CT scan already on this dog, and there was nothing on the CT scan. That's coming up to my splenic vein right there. And so again, looking at the spleen, no abnormal vessels there. All right, so for the next thing that we're going to do, we need to get a liver biopsy. And the way that I'm going to get my liver biopsy is because I've got electrocautery. What I'm going to do is I'm just going to take a big piece of liver just like that. And then I'm going to use my electrocautery. I'm just going to paint the surface of that cut liver. And there's nothing wrong with doing a liver biopsy in that fashion. So just painting that surface. And that's it. Can I please get some 2O PDFs? So we've got our liver biopsy here, and what we're looking for in this dog that has elevated bile acids, no evidence of liver disease, no evidence of a shunt on our CT scan or on XLAP. We're worried about the possibility of microvascular dysplasia, and so that's why we've done a liver biopsy. And now I'm just going to close my linea. I've got some 2O PDS. Now it's important when you close the linea, that's the false linea here. Okay, that's right in front of the prepuce. You want to make sure that you don't close that, but that you go all the way down and actually get the proper linea alba. All right, so just a reminder that we have our new channel, Vet Align, and I will put a link to the channel in the comments after I finish this surgery. But please subscribe to the new Vet Align and turn on notifications so that going forward you'll get a ding on your phone the next time I live stream. It's nice to be back on my old VetDojo channel. If you guys have any comments or questions for me, I'd be happy to answer them while we close. So I'm now working at the Melbourne Vet Specialist Centre in Glen Waverley in Australia. Loving it here. Really great team, great nurses, a good solid internal medicine team, which makes the caseload that I get fun and interesting. And a great dermatology team, which means I do a lot of TICAs, or total ear canal ablations, which are not as fun and interesting as a good abdominal exploratory, although I still quite enjoy them. So I'm happy to do a simple continuous in the linea alba as long as I'm confident in my knots at both ends. And you can see that where I've missed the linea, I only need to get the external rectus fascia when I close. You don't need to get both the internal and external rectus fascia. The other thing that I was looking for was acquired shunts that can develop near the kidneys. You should have been able to see them on the CT scan. And the reason why you get acquired shunts is because either you've got a fibrotic liver, which we definitely do not in this dog, or you've got a portosystemic shunt that you've ligated and the liver can't handle the increased blood flow, so they develop these new acquired shunts.
Are the abdominal shunts quite easy to visualize, or?
The portosystemic shunts, if you know where to look, yeah. So Jacob is asking whether it's easy to find on a normal exploratory. Look, if you weren't looking for one, it would be easy to miss.
Yeah.
Often they're down in that through the greater omentum where we made that little rent, and then looking in that that area kind of dorsal to the stomach. That's where I most often see them. And so if you, like, that's not part of my normal abdominal exploratory, but most of my XLAPs have had abdominal imaging and blood work and everything. So if we're suspecting a portosystemic shunt, like, we would know to look for it. The exception to that is that I did have the one case where I was just doing a routine abdominal exploratory and happened to find an extrahepatic shunt up against the diaphragm. So I'm going to leave Jacob to close the sub-Q, and then we'll go from there. So I'm just going to come over and make sure that there aren't any questions that... so there's a good question here. Why did we do bile acids in this dog in the first place? So the reason is that he was a young brachycephalic dog that had a history of a couple of seizures in one short period. It only had one episode of 3 seizures. Not sure what the cause of that was, but that's the reason why we did the bile acids, and then found that they were moderately elevated. They certainly weren't in the the mid-hundreds that I often see with portosystemic shunts. It was in the kind of the 50s. So another question is, why not sow the inner peritoneum? The reason why you don't is that it actually induces adhesions. So that's a research model that they use in mice to induce adhesions of organs to the body wall, which is by suturing the peritoneum. So no reason to suture it, and it does potentially induce adhesions. So another question is, although not related to the surgery, what happens if you don't do a bulla ostectomy and remove the lining if Fatica was done from otic tumor, not the infection? So if you remove the total ear canal but don't do a bulla osteotomy, what you're doing is walling off the inside of that bulla, which means that if you leave any of that lining or any secretory or infected tissue in there, it's going to form an abscess. So you absolutely have to remove the bulla lining and any of the contents when you're doing a total ear canal ablation. Now, if you did a canal ablation but were able to suture the skin to the horizontal canal, maybe halfway down the horizontal canal, I have done that for either tumors or traumatic amputations of the external ear canal. But then we've got an opening to the skin, and so basically that patient would still be able to hear, and you don't need to remove the bulla and its contents. But if you are going to remove that ear canal and remove the communication of the bulla to the skin, if you don't remove the lining, you're going to get an abscess formation. Hi, Malaysia. Hi, Canada. Bolivia. Hi, Stephanie. Hi, Brazil. Hi, Argentina. Hi, India. Hi from Seattle, Florida, Wisconsin, Toronto. So really great to hear from everybody. When you do multiple liver biopsies from different lobes with, say, culture and copper testing too, when do you do multiple liver biopsies from different lobes with culture and copper testing in middle-aged? Yeah, that's a good question, and I can't think of a situation where I've done multiple liver lobe biopsies. I think that most of the conditions that we're trying to find are going to be generalized. If we saw some irregularity on the ultrasound that suggested that there might be heterogeneity in what's going on in the liver, then we might do multiple lobes, but otherwise we don't need to. So just a reminder that most of my live streams are on VetAlign, spelled VetAlign. So please subscribe to that channel. I don't think that I'm going to continue. I don't think that I'm going to continue streaming on this channel. I'm going to go back to my VetAlign channel. So there's a question: is there no risk of intestinal strangulation with the rent and the omentum left behind? Not that I've ever seen. That's not something that that's a big deal. Certainly, so the omentum, I don't think has the potential to strangulate that mesentery would. And so certainly, if we're doing mesentery, we are going to close that hole in the mesentery, like if we're doing an intestinal resection anastomosis. But if we are doing just just opening a rent in the omentum in order to get a better look in there, you don't need to close that up. There was a question about the huge liver mass that I removed previously, and that dog has done very well, and that came back as a low-grade hepatocellular carcinoma, so that dog's doing great. Anyway, if you haven't already done so, please subscribe to both VetDojo and our new channel, which is VetAlign. I'm not streaming anything else today or probably this week, but I will get back to it next week. So great to see everybody. Hopefully we're picking up some viewers that didn't realize that we had switched to the new channel.